Next, we'll be discussing cell membranes. In this section, we'll be covering cell membranes and the distribution of molecules across those membranes. Shown in this slide are the distributions of various important ions across the cell membrane. Sodium, for example, has a very high extracellular concentration compared to its intracellular concentration, a difference of approximately 10-fold. Similarly, chloride has an approximately 10-fold difference in the concentration across the cell membrane. Calcium also has a very strong concentration difference, and note the very low concentration of calcium inside of cells, 0.0001 milliequivalents per liter. This suggests, and as we'll learn later, will confirm, calcium can serve as a very potent signaling molecule inside of cell membranes or inside of cells because its baseline concentration is so low. Potassium also has a substantial concentration gradient, but is found in the opposite direction of sodium, and over a 10-fold concentration gradient favoring the intracellular concentration of potassium. But note that despite these substantial concentration gradients of these various ions, the overall osmolarity inside and outside of cells is similar at approximately 290 milliosmoles per liter. This suggests, and as we'll find out, we'll confirm, that water is free to move across virtually all membranes to equalize the osmolarity across those membranes. This slide illustrates some of the important features of membranes and things that we should keep in mind as we talk about the physiology of membranes. Membranes are lipid bilayers, and these lipids are amphipathic, and that is they have two different sections. We have a polar section shown here with the green ovals, and a longer nonpolar section shown with the green squiggles attached to each of these ovals. The nonpolar sections will associate with each other, and the polar sections will associate with the extracellular and the intracellular fluid or cytoplasm because these fluids are polar in nature. There are multiple other proteins and other molecules that are associated with membranes. Shown on the outer leaflet is a receptor glycoprotein. The glycosylation portions of these extracellular molecules tend to be important for recognition of specific extracellular molecules. Other proteins span across the membrane and can have important roles in signaling, and as shown here on the right of the figure on the left is an integral membrane protein which serves as an ion channel. Other proteins are found on the inner leaflet, shown here this yellow protein D or B, and these proteins tend to serve structural roles. Shown on the right is the ability of various molecules to cross membranes. All gases of biological importance, such as oxygen, carbon dioxide, and as we'll learn later, nitric oxide, are free to traverse cell membranes. Water is also free to traverse cell membranes, not because it can float through, but because most cells have channels called aquaporins to allow water to pass through those membranes. Other molecules of biological importance, such as proteins, carbohydrates, and ions, because of their polarity, are unable to cross cell membranes, and therefore, as we'll learn later, have specific mechanisms to allow them either to cross or to signal across cell membranes. Before we discuss the movement of water across membranes, we need to define some terms. Isotonic refers to two solutions that have the same osmolarity. Hypotonic situations, by convention, refer to the situation where the extracellular solution has a lower osmolarity than the intracellular solution. Hypertonic, conversely, refers to the opposite situation, where the extracellular solution has a higher osmolarity than the intracellular solution. It's important to understand the effects of tonicity because, as shown in this slide, altering the tonicity of a fluid will alter the size and shape of a cell. Shown in the middle of this slide is a typical biconcave red blood cell. The biconcave shape is very important for these cells to conduct their normal function. When these cells are placed into a hypertonic solution, as shown on the right, water will leave the cell in order to normalize or to attempt to normalize the osmolarity in the intracellular and the extracellular spaces. As water leaves the cell alters its shape, it gets smaller and is referred to as being a crenated red blood cell. Conversely, when red blood cells are placed into hypotonic solutions, water will enter the cell again in order to normalize the osmolarity across those two spaces. And as that happens, the cell will swell and in some cases will burst. And that's shown here on the right. There's substantial clinical relevance in understanding how osmolarity can work, and we'll learn about 3 different situations where osmolarity can serve either as a toxin, where osmolarity can serve as a therapeutic agent, and when osmolarity can be used as a diagnostic tool. In our first example, we'll describe osmolarity as a toxin. This process is known as central pontine myelinolysis, otherwise known as iatrogenesis imperfecta. Here's an example. A patient rolls into the hospital with a sodium of 108 and drowsy. Of note, this is a low sodium value. It's July 1st, and Joe Gunner, PGY1, on the first day of his residency, starts 3% normal saline at 100 cc's per hour in an attempt to elevate this patient's sodium. On July 2nd, the patient's sodium has risen to 140, which is normal, and the patient is alert. On July 4th, the patient is dysarthric, and he has dysphagia, that is, he has difficulty speaking and he has difficulty swallowing. And on July 5th, he has mild quadriparesis, which is worsening, that is, he has forelimb weakness, which is worsening. Shown on the next slide is an image from this patient. This is a FLAIR image, and the important point to note here is the white image, or the white signal shown in the pons in this image, shown in the center of the brain. This refers to demyelination of the pons, and this demyelination is caused by the rapid increase in the osmolarity of this patient. That rapid increase in osmolarity will drive water out of cells, and the cells that are most sensitive to the rapid efflux of water are the axons found coursing through the pons. And this is responsible for this patient's dysphagia, dysarthria, and quadriparesis. Another point where osmolarity can be used is when osmolarity is used as therapy. As shown here in the figure on the left, this is the brain of somebody who has a very swollen right temporal lobe. The swelling could be due to any number of factors such as stroke, infection, or tumor. This swelling itself in life needs to be addressed because, as shown here, the swollen right temporal lobe is distorting the architecture of the midbrain shown in the center of the slide. The major pathology here is brain edema. First-line treatment is to decrease the edema through some sort of osmotic manipulation. Mannitol is typically used in this situation because mannitol has a very high osmolarity, and this high osmolar administration can cause the outflow of water from the swollen temporal lobe, which can temporarily decrease its size and relieve the pressure on the midbrain. Any high osmolarity solution could work in this situation, and the important point to recognize is how osmolarity in the appropriate situation, high osmolarity that is, can serve as a therapeutic tool. In addition, osmolarity can serve as a diagnostic tool. As mentioned earlier, the normal osmolarity is typically around 290 milliosmoles per liter. But it's important to recognize that this value can vary throughout the day. So for any given patient, their osmolarity may vary from between 280 to approximately 300 milliosmoles per liter. One way of understanding whether or not a given patient's osmolarity is abnormal for them is to calculate what their osmolarity should be. We can look at the major species, major osmotically active species in the patient's blood to gain a rough estimate of what a particular patient's osmolarity should be. This is done with the following equation. 2 times the number of sodium ions will account for the vast majority of ionic species in the blood. Glucose is another major source of osms in the blood, and the glucose concentration is divided by 18 in order to adjust the units such that the units match between sodium and glucose. Similarly, blood urea nitrogen, or BUN, is another major source of osmolarity in the blood, and that's incorporated into this equation as well, and is also divided by a correction factor of 2.4. This osmolarity will always underestimate the real osmolarity because it doesn't account for the many other osmotically active particles in blood. In order to account for that, we have another term known as the osmolar gap. The osmolar gap is the measured, or the real, osmolarity minus what is calculated using the 3 molecules shown above. And normally, the osmolar gap is anywhere between 10 and 15 milliosms per liter. Shown in the next slide is an actual case taken from a neurology journal, and the reference is shown at the top. So a 38-year-old man is brought to the emergency department after being found with decreasing responsiveness. On exam, he is comatose with normal vital signs. He's given thiamine, dextrose, naloxone, and flumazenil, which do not help reverse his decreasing responsiveness. An emergent brain CAT scan and MRI are unremarkable. His routine toxicology panel is negative, and his blood alcohol level is 20 milligrams per ml, which is less than the legal limit. Shown in the middle of the slide are sodium, potassium, chloride, bicarbonate, blood urea nitrogen, creatinine, and glucose values, which are all normal. However, his measured osmolarity is high, 337 milliosms per liter. And one question we can ask ourselves is, how high is this relative to the expected osmolarity for this given patient? We can use the equation shown 2 slides ago to figure this out. If we use the given values for sodium, glucose, and BUN, plug them into this equation, and calculate this patient's osmolar gap, we find that his osmolar gap is 53. This is quite high. And what we've learned by doing this is that there is a major source of osmoles not yet accounted for by the routine labs that are taken as shown in the previous slide. And our mandate as physicians is to understand where are the missing osmoles. In this particular case, the missing osmoles came from isopropyl alcohol. This is a small molecule, and small molecules are able to accumulate into large numbers to produce a high osmolar load. So it's important to recognize that any small molecule can do this, and routine toxicology testing would not reveal isopropyl alcohol. This would only be looked for under the right clinical context with a suspicion which is driven by this high osmolar gap finding. So the key here is to recognize this high osmolar gap. Final example of how osmolarity can be used as a diagnostic tool has to do with the effect of osmolarity on red blood cells. And as shown several slides ago, osmolarity can have a potent effect on red blood cells, such that increasing osmolarity can shrink red blood cells to cause them to be crenated, shown on the left, and decreasing osmolarity can cause red blood cells to swell, as shown on the right. The shape of red blood cells is typically maintained by a series of proteins that comprise 3 different kinds of proteins: the band 3 proteins, which are part of the cell membrane, the ankyrin linker proteins, and spectrin, which is part of the cytoskeleton of red blood cells. These proteins protect the cells from these changes in osmolarity, which can cause the cells to swell or shrink, shown in the previous slide. Hereditary spherocytosis is a disease of the red blood cell membrane where there is defective or low levels of band 3, ankyrin, or spectrin. Most commonly, the disease is found with the levels of spectrin, although it could be any one of these 3 proteins. Patients with this disorder have red blood cells that are spherical in shape, resulting in decreased surface area, and these cells are not efficient at gas exchange and become destroyed in the spleen sinusoids. One way of making a diagnosis of hereditary spherocytosis is to perform what's called the osmotic fragility test. This test is a way of assessing the effect of osmolarity on red blood cell integrity. Shown in the top right is a series of test tubes whereby red blood cells were placed into various concentrations of saline. As the saline osmolarity was sequentially decreased, one observes an increase in red color, and this red color is due to hemolysis caused by the low osmolarity. Shown in the bottom of that figure is the same experiment done for red blood cells taken from somebody with hereditary spherocytosis. And what's shown is that with very small decreases in osmolarity, just slightly below normal, one already observes a red tinting of the fluid. And this red tinting again is caused by hemolysis. This suggests that red blood cells in patients with hereditary spherocytosis are much more fragile, that is, are much more susceptible to the decrease in osmolarity causing these cells to swell and burst. This phenomenon can be plotted and shown on the left as an increase in hemolysis as the sodium chloride concentration or the saline concentration decreases. The thick orange line refers to normal red blood cells. So these red blood cells at concentrations of 0.45 or 0.45%, which is half normal saline, show almost no hemolysis. And as you lower the sodium concentration further, they begin to hemolyze more. On the left is a similar curve but shown for patients with hereditary spherocytosis. These patients at very small decreases in osmolarity relative to baseline already begin to show hemolysis. And by the time you reach half normal saline or 0.45%, one already sees that approximately 90% of red blood cells are hemolyzed. And this serves then as a very sensitive diagnostic marker for hereditary spherocytosis. That concludes this section on cell membranes. Next, we'll discuss receptor physiology.